I'm going to apologize first. I have a little bit of a minus thing happening, so hopefully I won't cough right into the phone while I'm talking. But I'm going to talk about oral cancer in underserved populations. And if we go to the next slide, I can tell you some about the demographics of oral cancer and some of the fundamental aspects of oral cancer. So it's not one of the most common cancers, but the outcomes are uniformly poor. And so in that sense, the mortality is relatively high. You can see that oral cavity and oropharyngeal cancers occur most often on the tongue and the tonsils. The tongue is considered to be part of the oral cavity, and the tonsils are part of the oropharynx, and some of the salivary glands, and then there's some others that are lips and gums, the floor of the mouth, and some other sites. And as a group, these are also often referred to as head and neck cancer, which can get a bit confusing, but I'm going to refer to things mostly as oral cancer and oral squamous cell carcinoma in this presentation. In the year of 2012, the estimate is that about 40,000 people will be diagnosed with this disease, and about 7,000 people will die. For a long time, the greatest risk factors for this disease have been tobacco and alcohol, but recently there's been an increased development of cancers of the oral cavity in a relatively younger population and suggesting a different etiology, and this etiology has in fact been defined as human papillomavirus, or HPV. Africans are diagnosed at younger ages, but with more advanced disease than any other racial or ethnic group, and are 2-3 times more likely to die from their disease than Caucasians, both nationally and in Tennessee. And here I'm talking specifically about African American males. Men are more likely to have oral cancer than women are, and then Caucasian and African American men have a similar incidence, but African American men are much more likely to die from their disease at any given time. Interestingly, I won't talk about this too much, but if you look at Tennessee, African Caucasians are 2 to 3 times more likely to die from their disease than Caucasians in Western and Middle Tennessee. And so this is suggestive of a strong link probably to socioeconomic status, but again, it's a multifactorial disease. And so we'll talk about some of the things that probably contribute to this disparity and what we're trying to do about it here at Meharry. So on the next slide, it's just a diagram of the mouth, and here we're talking most part, we're going to talk about tongue and oropharynx. So back here, what also would be the soft palate area and the tonsils. There's thought that the HPV associated form is here, that this is a similar biology to the cervix, and we'll talk some about the HPV types that are most often detected in oral cancer. And these are just a couple of images that I got off of the internet of leukoplakia, which is kind of a precancerous condition. It doesn't necessarily mean that a cancer is going to form there, but it's a risk factor and it should be taken seriously when it's seen. So you can see the white blood cells collecting here. And this is a squamous cell carcinoma of the floor of the mouth. So this would be like the back of your tongue here where it's attached. And you wouldn't think they could get this advanced before people come to the doctor, but in underserved populations, you see that in fact they can be very advanced when people come, as for some other cancers. If we go to the next slide, incidence by gender and race, and this is off the SEER database, and this graph is actually right out of National Institutes of Dental and Cranial Facial Research that funds a lot of oral cancer work and also dental work research. And you can see here that if we just look at gender, male and female, by race, and most of the population that we see, so I'm going to tend to talk about, is as unserved Caucasians and unserved African Americans. Meharry serves an underserved, multiracial, multi-ethnic group, and the hospital that's associated with us is City Safety Net Hospital. So we see a lot of indigent and homeless and underinsured and uninsured people. Here, if you look at for incidence, and you look at males, you can see here that for white and African American, they're essentially the same. And females, as the trend you'll see is that generally a half to a third in incidence. Here we have Asian Pacific Islander, American Indian, Alaska Native, and Hispanic, where the incidence is uniformly lower for males. If we go to the next slide, then we'll see outcomes. And so this is where you really see the disparity. If you look at death rates by race for oral cancer in males, you can see here that for people classified as Black, so that is anybody of African descent in the U.S., not just African Americans, so first-generation immigrant from Africa. It includes some 50 or 60 countries of origin generally. But you can see here that this is about quite twofold, but if you look in different areas of the country, you'll see something more specific. In Tennessee, again, it's about a threefold difference in mortality. Notice the scale is different here. This is death rate by race for oral cancer for female, again, per 100,000. The rate is lower to begin with. This is 1.4 and 1.5. The scale makes it look like it's much more different than it is. So this disparity really exists in income for males, for African American males. African American females have a similar incidence and a similar outcome to Caucasian females in the United States. So these clues is something that's going on. I have probably more questions than I have answers. But if we go to the next slide, I'll just show you the disparities in Tennessee, specifically where I am. This is Shelby County, where Memphis is. This is Davidson County, where Nashville is, where I am. Most of these are not filled because there's simply not enough African American or individuals self-identified as Black to make the statistics solid. So it's only reported for these two, which are two of the more kind of urban areas. And so if you look at Black and white in Davidson County, here you see that threefold difference. Here it's also about threefold, 2 to 3-fold for Shelby County. And this is what I was referring to in regards to Appalachian whites. And so here we're over here now in the mountains. And you can see again that although I failed to put the numbers here, 6 and 7 per 100,000 in the death rate. So again, suggesting that access to care, insurance, and are certainly a major driver in disparities in outcomes. If we go to the next slide, we will talk about stage at diagnosis. Can you let there? Okay. Okay,
now I can hear you.
Okay. Stage at diagnosis. We know that for oral cancer and for every cancer, that your stage at diagnosis is really important as an indicator of outcomes. And if you're diagnosed with localized disease, that your outcome is going to be much better. An obvious question when it comes to underserved individuals: who's likely to go to a primary care physician for a yearly physical, less likely to go to the dentist, often presented at the ER with dental issues because it's gone so far. So we can ask, stage at diagnosis is prognostic. Is that also the case for oral cancer? And so you can see the 5-year relative survival rate. It's for all races. For localized disease, 80% of people alive after 5 years from diagnosis. If you've had regional disease, so it's spread from the primary tumor, but it's in your tongue, so it has broken out of the primary tumor, but it's still in the tongue itself. But once that happens, often there's micrometastasis that you can't see. So you can see a great drop there in 5-year survival down into the 50s. And then distant metastasis, so lymph nodes or another organ, in 5 years, less than 30% of people who are diagnosed with distant metastasis will still be alive. If you look at disparities in the stage of diagnosis, here you can see this, I think, to look at this from the top. So this is a percent of stage distribution at diagnosis by race or ethnicity, each one is for both males and females at this point. If you're looking at localized disease at the time of a diagnosis, Black males in the United States have a much smaller bar there. So it looks only about maybe 22% are diagnosed with localized disease relative to other demographic groups by race or ethnicity. And then if you look here, these both are starting about the same point with unstaged down here. You can see also quite a bit of a difference in distant metastasis. So that's the worst possible outcome relative to the white population. And if we look at the next slide at disparities in stage of diagnosis, and now I've just looking at the groups that we see mostly in our hospital, but also by gender. So we have Black males, Black females, Hispanic males, and Hispanic females without an indication of race. And then here the designation is non-Hispanic white, and which generally correlates pretty well with people who define themselves as white. So again, if we go back here, we see Black males, localized disease very small, Hispanic males, localized disease is a bit larger, Hispanic white males, much larger of localized disease. Females in general, whether this is because they're more likely to go to the doctor when they see something wrong, are doing a little bit better in their stage at diagnosis than any of the male counterparts in their same demographic group. So you can make, I think it's too much of a leap to suggest at this point that a late stage at diagnosis, whether that's because of a different type of disease or if it has to do with socioeconomics or just not wanting to go to the doctor, is probably contributing somewhat to this disparity in outcomes. However, if you look at the next slide, which is, it shows that African American males have lower survival even when you control by stage of diagnosis. And so here if you look at, and I'm sorry colors aren't right on here for this one, but white and African American. So if this is localized disease controlled for various factors and only allowing stage to drive it, you can still see that the outcome for African American males is poorer. And so that then suggests that something in addition to stage diagnosis is contributing to this disparity. The next slide, we can talk about one more issue, which is one that I'm doing a little bit of work on that has to do with outcomes, which is Hpv status. And so when you look at people now who have oral cancer, but it's HPV positive or HPV negative, HPV positive is really a different molecular disease, and it across the board responds better to therapy than that which is either idiopathic in its etiology or that's developed in people who are long-term users of tobacco or alcohol, or the two together, which really is synergistic. Depending on the demographic group, 50% or greater of the oral squamous cell carcinomas or the oral cancers, of which about 95% are the squamous cell carcinoma, may be HPV positive. It is generally an independent risk factor for cancer. And so what you'll find in this group is that they're generally not historically users of tobacco and or alcohol, and that HPV is really the major risk factor from having developed an oral cancer. And again, it's really important to point that HPV positive tumors respond better to standard therapies than HPV negative tumors. The genetic and molecular changes that are driving the cancer are just plain different in HPV positive and HPV negative tumors. If we get the next slide, and I just risk factors, although I just sort of did that, is historically, again, tobacco and alcohol, you saw predominantly males in their 60s and 70s with a resulting cancer most likely from long-term use of tobacco and alcohol. Alcohol risk is associated with quantity and not type, so it can be something that you made yourself or something that came in a bottle that cost $200. If you consume a lot of it, it's the same risk. Tobacco can be in any form, so it's not just smoking. It can be chewed, it can be snuff. In other countries and other cultures, there's a leaf called betel that people chew, and betel is also a risk factor for oral cancer. Again, tobacco and alcohol function synergistically, and the more recent risk factor is HPV. And another important point to keep in mind is that HPV-positive oral cancers, again, are more likely to be located in the oropharyngeal region, and including the base of the tongue and the tonsils. We go to the next slide, a little bit about HPV-positive oral squamous cell carcinoma. The cervical cancer subtypes are dominant in oral cancer as well. HPV 16 is about 80% of them in the United States, and 18, which is the second most common in cervical cancer, is also generally the second most common in oral cancer. The risk factors for HPV-positive oral squamous cell carcinoma are also independent of the smoking and drinking, and these include a large number of sexual partners and practicing oral sex. A paper that reported a few years ago that the demographic group that's most likely to present with HPV-positive oral cancer is Black males who have never been married. And I'm sorry, I left off a parenthesis there. We'll talk a little bit about this report. This data came from the SEER database. And people will ask at this point, is this to have sex with males? And I don't think that that's a parameter that's included there. But they're a particular high-risk group for oral cancer and also for anal cancer, which is also uniformly HPV positive. Oral prevalence of HPV in racial and ethnic minority groups is not well characterized, and so where it is in the mouths of most people is not very well known. It's thought that maybe 16 to 25% of adults in the United States have HPV in their oral cavity. But just like for cervical cancer, most of them will not progress to cancer, and this one is still a bit of an unknown, just as it is for why a small portion of people get cervical cancer when they have HPV. When we get to the next slide, and again, we talk about where do we tend to see HPV-positive oral squamous cell carcinomas, and again, we tend to see them in the tonsils and at the base of the tongue. And this paper from Chaturvedi, where he's looking at HPV epidemiology, what he's really doing there is he's using anatomic site as a proxy. So this is SEER data. There's no tissue to go with it. But the idea that a large proportion of a tonsillar and other oropharyngeal tumors are likely to be HPV positive, he classified on that site by anatomic site as HPV related or HPV unrelated. And so your cheek would be HPV unrelated, but your tonsil would be HPV related, for example. And what he found when he looked at that data is that there's an increase in HPV related regions in mouth for oral cancer and decrease of HPV unrelated. And around 2004, these converged. So with the decreasing HPV unrelated, that for smoking and for drinking alcohol, declining, and that increasing for the HPV related. And these actually have continued on their trajectories since 2004. And again, in some populations, the HPV related or HPV positive tumors are the dominant. Again, this is the paper that suggested that HPV related anatomic sites, which are tend to be a group that's slightly younger. At that time, there's still going to not be such a large number of HPV related to kind of make a big difference in the age at that point. But basically, we're starting to see a slightly younger group, Black, male, and never married. And that was the conclusion from this paper. And what you'll see as we move to the next set of slides is that this idea that Black males are more likely to have HPV positive is not really supported when other people look at the literature or start to look at their slides. And the suggestion, as you'll see as we go through these, is that the disparity in outcome is really because HPV-positive tumors are more likely to appear in Caucasians, and we know they respond better to therapy. But you can judge based on what I show you, what you think. And just quickly, from 2009, overall survival disparity linked totally to oropharyngeal disparity in response to chemoradiation that results from a disparity in HPV status. And so in this group, they had pretty good numbers. Sometimes you'll see 200 whites and 20 black, and trying to do an analysis on that. But they did have tissue in this case, and they looked at the disparity in outcome. When they looked at outcome, there was no site that predicted this disparity other than the oropharyngeal region, which is where you tend to see the bulk of the HPV-positive tumors. And they actually were able to look at HPV status in theirs, and that, in fact, for their particular set of about 200 individuals, that this disparity in outcome was really driven by the location, which was driven by HPV status. And so this, in fact, supports the idea that this group of people they were looking at, that HPV status was actually predicting the poor outcomes for individuals that identified themselves as black. In the next study, here where the numbers are a little bit more difficult, they only have 25 black patients and are less likely to have HPV active head and neck or oral squamous cell carcinoma than white patients, and that's a 2010 study. But they, again, also were able to do PCR to look for HPV and another marker of whether it's activated or not. So is it just sitting in there not doing anything, or is it an active virus, which is P16? And they showed that the favorable HPV active disease class is less common in black than in white patients. And, they nicely indicate that it appears to partially explain observed ethnic health disparities. And I think that we're always going to have to be able to conclude that there are a lot of factors driving this. There's just one more from 2011. And here they actually are reiterating this idea that black patients are more likely to be diagnosed with advanced stages than whites, and after you adjust for socioeconomic status, insurance, and other confounding factors, that the outcomes are still different. And so, do we have that one? The next slide. Thank you. And basically, they're again suggesting that it's really important in these kinds of studies to include biological markers as well. So, in fact, if you control for socioeconomic status and insurance and other factors, that sting is a predictor of poor outcome, but we need to really start looking at HPV status to better define this. We need a cause or we can't change it. So that's what I lead into with the next slide, which is really what can we do to lessen these disparities in mortality. And these are some things that we're doing here. And we're to do a lot of stuff on a fairly low budget, and one of the things that you can always do if you can make the time for it is to try to educate, do education outreach, and we do them through free screenings. And, you certainly want to talk still about smoking and alcohol, about HPV, about seeing the signs for oral cancer, and go sooner rather than later if you see a lesion in your mouth that doesn't clear up after a couple of weeks. And then another thing that we do, because I'm basically a lab person, I've become a population person, but I'm really a lab person, which is how I came into this area of work, and to identify and develop biomarkers for easy detection of either precancerous or early cancer cells in the mouth. And there are uniformly poor outcomes for people with oral cancer, and so this is to the benefit of everyone, and you hope that would disparately benefit those who disparately are bearing the burden of poor outcomes. So if we go to the next slide, I have a few pictures from some screenings that we have done. We're actually over in the dental school here, and we do 2 or 3 screenings a year. We have all of the people in the green scrubs here are dental students, and this is Avbu Ogbidi, who's actually a 4th-year medical student now and is interested in otolaryngology as a field and has done laboratory work with me too on a biomarker. Dr. Avi Jalori, who's a periodontist. Dr. Corey Jones, who's a lab person but also does a lot of work with human subjects protections and clinical trials. That's me and another dental student, and here the students are in the one of the clinics. They open up a couple of rooms for us when we do these, and they don't schedule the regular dental patients in, and then we can go in and screen. And in the next slide, we'll just show you the one of the advertisements and the questionnaire. It's we actually have developed one that collects a bit more information, but when we're doing screenings and we're real busy, often we just do the more brief one. These are from the Head and Neck Cancer Alliance, which was formerly the Yul Brynner Head and Neck Cancer Foundation. You may have this on the first slide. I had Sammy Davis, who is probably one of the better known public personalities to have died from oral cancer. Yul Brynner had oral cancer, and then he ultimately died of lung cancer, but he developed this foundation to address head and neck cancer. It's now called the Head and Neck Cancer Alliance. Once every year is Oral Head and Neck Cancer Awareness Week, or OHANCAW, and I was encouraged to sign up. They put you on their site, on their map. People can see if there are any locations around them doing the screening. It's usually the last week in April or early in May. And then we just do this big screening. It's now become quite international. Everybody fills out the form, and then I can show you from our screening last year. So on the next slide, how many people we screened and a little bit about them. Last year we had 25 people come in. We had 6 females and 8 males, and you can already see the problem there. Males are much more likely to have oral cancer, and African American males are much more likely to die from oral cancer, but we have 2 times as many females come in to be screened as males. This is an interesting year because usually we have more local people, and we spend a lot of time recruiting in even that day for people to come in. This time we had 14 zip codes, and none of them were ours. And if you remember, last year was the year that Michael Douglas announced that he had oral cancer. And he was on Oprah Winfrey the week before the oral cancer screening, the national one, and he encouraged people to go to the site. And my phone started ringing off the hook, and I actually wrote a piece that's in my collaborations newsletter that we have that addresses what I call the power of O, which was oral cancer and Oprah, because it happened to everybody. People just started calling like crazy. Do I need an appointment? Where do I go? And so we really did very little local recruiting that day because we had people driving even up to an hour to come here to get screened. For tobacco use, we have 15 people who used tobacco. 4 were former, so 11 current. And the numbers don't add up very well. 5, 6, 7, 8, 9, 10. It's close. 5 cigarettes, 1 cigar, 1 snuff. 3 people didn't indicate the form. Alcohol use, we had 6 people indicate yes. It says 7. So again, I apologize. 7 people said they had 2 to 5 drinks per day, and then I think this is actually a much smaller number here, and then 5 people had no answer. We referred for abnormalities of the oral cavity or pharynx or larynx. Often these were dental issues, and this was a year when we in fact didn't see any suspected plasms. Last year we referred 4 people, and we're lucky because we have an ENT clinic, and we can simply then direct them with names and times in which they could go and then see a doctor for a more thorough evaluation. And so even though our numbers are smaller than a lot of the larger institutions, I think it's a real valuable service. And you saw the table with all of the information. We really tried to get out a lot of information about oral cancer, about smoking cessation, and even just some general literature on cancer. As you probably know, African Americans have uniformly poor outcomes from many cancers, including prostate and breast and colon. So we try to educate as much as we can. The worldwide results are in the next slide, and you can see here that over almost 12,000 people were screened. We contributed 25. There were 295 sites that were involved, and they really are around the world. And so I encourage you in April to go to the Head and Neck Cancer Alliance site, see who in your area is doing free screenings, and encourage the people that you see in your clinics go for an extra kind of boost of screening. In the next slide, I'll talk about another initiative that we have here, which is we have a head and neck tumor tissue repository and clinical database. That's my IRB approval number up there. And like this saliva and buccal cells, and then blood that we process in different ways. I'm going to show you a little bit of data on some biomarkers from serum eventually, and but my preference, and I think you'll agree that the place you really want to go for biomarkers is saliva or buccal cells, because you can more easily attain those. You don't need a special license to draw blood if you ask somebody to please expectorate into a tube. We have 28 people involved. We have no problem getting people to agree, and I think that's probably an important point to make here, that across the board, our patient population is very willing to be involved in research, including clinical trials where different types of therapy are given for cancers where the therapy is not very effective. And so I think my philosophy is that if you offer people that they are quite willing to participate. In a bank, we have 9 Black, 16 and 1 Hispanic. Our patient population, again, is probably the identifier, the uniter, is being poor, uninsured, underinsured, and we do see Black, white, Hispanic, a lot of first-generation African immigrants also. Here you can see again, this just reinforces that males are much more likely to have oral cancer than females. We really have anybody turn us down for the bank, and so I think this is a really good reflection of what we actually see here, and you would see this also if you went into the 200 or so patients that are treated here in the last since about 2000. And so, one of the things I mentioned was the one thing maybe we can try to do in addition to screening education involves biomarkers. What can we look for that might be predictive of increased risk, or, inviting somebody for much more frequent visits to actually look in their mouth and see what's going on and possibly continue to sample. Sort of like PSA for prostate cancer. So this was some work done by Wendell Yarborough, who is a collaborator that I was introduced to when I came to Meharry, and he was at the Vanderbilt Ingram Cancer Center. He's just recently moved to Yale, which is unfortunate for me. But they had identified some proteins that appeared to be present at higher levels in the serum of people with late stage, so stage 3 or 4 oral cancer. And part of what we've been doing for the last couple of years is following up on some of these. And number 7, what's called FETUIN A, also AHSG is another way that it's referred to. You can see here, it's about 4 to 1. Levels in the serum, and this was really interesting and intriguing, and we decided to follow up on this for a number of reasons. And so if we look at the next slide, and we'll tell you something a little bit about this protein. So it's primarily produced in the liver, and so what it is that you see in the serum is generally liver-derived. Role in the body is mostly known in bone formation. It binds calcium and it helps with bone formation remodeling. It also has another thing that's interesting about it, is that you get really sick, whether it's cancer or a cold or whereas any kind of disease stress on your body, that it's a protein that the liver will kind of cut down on making so much of it. So it's called a negative acute phase response protein, but again, what that means is that in high disease load, that the levels are measurably decreased in the serum. And if you remember, what we saw was very high levels in the serum, which in people with a very heavy disease load. So that doesn't make so much sense on the background of the idea that this is the form of the protein that comes from the liver. Low serum levels predict poor outcome in late-stage glioblastoma, and there's a reference at the end about this. So when we talk about this molecule fed to an HSG, and we talk about this particular kind of brain cancer, as levels drop, the prognosis becomes more poor, and the mortality outcome is becoming more imminent. We don't see low levels, we see high levels, and so that's really interesting. It's particularly interesting because in some animal models for lung and breast cancer, a lack of this delays tumor formation. Okay, so then you think, well, does more of it promote tumor formation? And do we in fact have a case where a tumor itself is making this molecule and some is actually spilling into the serum? So that's really our question. Breast cancer cells, they take it up from the serum, but it's the liver form and they use it for growth. But it appears to us that actually the head and neck cancer cells make their own. So we thought this was a really interesting story, and there's a graduate student working on this right now. Her name is Pam Thompson. In the next slide, though, you'll actually see a bot that I did. I'm not often allowed to touch things in the lab anymore because I'm not very good at it anymore. But these were some cell lines here. Here's primary tonsil, primary tissue, so tonsil, a tumor, another tumor. You can see that a couple, and there's an antibody against this, so we run this protein out from the cells or the protein extract from the primary tissue. We transfer the protein onto a filter, and then we bind antibody to it that's labeled. And you can see very clearly here that a couple of these cell lines are making it. They appear to be making a bigger form than the primary tissue. And we've got one tumor that seems to be making a lot more than another tumor. But this was just our first question, is should we look at this anymore because, you know, it's actually be made by these cells. There's a whole other seminar that's not going to happen right now that involves how far we've come with this, but we've been able to knock it out of some cell lines, and we can see that it really affects their growth, and we're going to be able to put these into some animal models and watch and see how it affects the ability of the tumor to grow in there. And so we're really hopeful that this is something that may give us some insights into a way that head and neck squamous cell carcinoma grows. In the next slide is just quickly an issue. We're talking about this molecule is very interesting. We can just talk about the quantity like we just did, but we also know that there are different forms of it. And there's a particular form that's present only in people of African descent and not in people of Caucasian or who classify themselves as white. So our first question is just about how much we have of the particular variant that we're working with, and we still need to get it sequenced and see what it is. But another thing we want to be able to do is to actually look across tumors and see if we also have a difference in the quality of it, which so also affect the way that it behaves in the cancer situation. Thing is another project that we're working on here, and we're just starting this, but we really also wanted to say, well, you know, we have 200 and some really nice tissue blocks from the last 10 years of treating patients here. We have more than that, but we wanted to work with the newer ones because the integrity of the tissue tends to be a little bit better. And so this is Hpv status of archived pathology samples. Routinely checked because the therapy is the same, but so we wanted to just go back and say, not say it's oropharynx, so it's HPV. Let's actually go in and see if we see HPV. And so this is a project that we're just getting started with, and we have a little bit of money through an award that's we're able to access through Vanderbilt, with whom we've had a very good and formal working relationship for about 12 years now through the Meharry Vanderbilt Alliance. So I have no data on that. Maybe next year's seminar we'll talk about that. And so in summary, again, lots of questions, and we're heading off in some different directions to try to answer these questions. But we do know, without a doubt, no matter what database you look at, African American males have a similar incident rates of oral cancer to Caucasian males. In the United States, they die at a rate 2 to 3 times greater. African American males are more likely to present with late-stage disease than any other group. Although socioeconomic status with resulting limitations in access to care play an important role in this disparity, there are suggestions that a more recent change in etiology involving HPV may also play a role, and this really requires some additional research to confirm. The identification of biomarkers of precancerous conditions or cancer that's yet to be seen is really an area that we want to work in. I want to make a point, and it looks like I missed a slide I simply didn't get it into here, but the average age for our tissue bank is only 52, and so that's way below what you see in any of the databases, which again is a clue to something, and we really don't know what it is because it is such a multifactorial disease, so I just wanted to point that out. Outreach and education through free screening for oral cancer is really critical to our efforts to decrease mortality for this disease. And I think that's what I have. I have a reference, if we could put that up, and just to show the references for the things that I referred to in my presentation. And then the next thing is people who have participated in a lot of what you've seen and heard in this last 45 minutes or so. And the medical student who's worked with me a lot is in her 4th year rotations, Avbu Ogbaidi. Keith Payton, who's a dental student who has done a lot of the screenings, and he's also going to graduate in 2013. Dr. Bellard, who is my chairman, he's a dentist and MD, a pathologist by his subspecialty, both dental and medical. Some of the dentists, some people that mentioned, Lena Walker, who has worked in the lab. A lot of dental students that come in and screen for an hour during these, and I don't even know who they are, and I apologize, but the dental school does a great job of staffing the screening days. It's a great experience for the 3rd and 4th year dental students. Pam Thompson, who's a doctoral student with me, Dr. O Chang, who has done a lot of the work I referred to in the animal models with the lung cancer and the breast cancer and the FET2NA, and Amos Sackley, who also is in the research group with Dr. O Chang. My greatly missed Vanderbilt collaborator, Wendell Yarborough, and people in his lab who really have been instrumental in helping us in setting up the screenings, which they had done for years, and including us in their advertising because their budget was larger, and also in lab work that I was doing. And then somebody I didn't mention, but John McLean, who is a mass spectrometrist, and he's going to also help us look at different forms of FET2NA that come from different tissues, and we're doing that now as well. Thank you for listening, and if there are any questions, I'll be happy to take them.
Thank you, Dana. I hope everybody can hear me. And we are certainly open to questions. Please unmute yourself if you would like to ask a question. And if you have no questions, session. But let's see. Does anybody have any questions? I actually have a question. Okay. Of course, I'm coming at this from the perspective of a social worker and not a medical doctor. But impact do you believe the HPV vaccine is going to have on this, or has anybody started a long longitudinal study on impact of widespread HPV vaccination on oral cancer?
Yeah, so that's a very good question, and the delay to the cancer presentation is also going to be a long longitudinal study. There's actually a lot of work being done here looking at vaccination and the completion of the series in females. It's only recently been approved and now promoted for males. As I was at a Disparities meeting a few years ago, and someone from the International Cancer Research Group was there. I think it's IC, but and said you can't treat an STD if you only vaccinate half the people. And so, HPV is definitely an STD, and oral cancer is
right.
STD if it's HPV positive. So it's been thought out, and the girls who are fairly young. I think they just increased the age maybe to 26 for women. I don't think it was quite that high before. But in the population here, 50% get the first vaccine, and then less for the second, and then the drop off for the third is So you're absolutely right, and you would expect that it should have far into the future an effect. But you certainly are going to have to also really look at vaccinating males. And even though it's just been approved, I don't think it's quite as intensive as it is. Females, they don't want cervical cancer. With males, you're having to say, do you want your partner to get cervical cancer? And it's not really promoted as an oral cancer vaccine because there is not a whole lot of work that's been done. So you're right. I mean, that's exactly the perfect question about this, and hopefully we'll see that in fact it does cover, as well as anal cancer is becoming more common. It's always HPV positive as well, and it's really becoming somewhat of almost an epidemic in some of the cancers that are resulting where it hasn't been seen before, and this is really thought to be driven a lot by changes in sexual practices. And particularly for young girls who don't believe that oral sex is sex. And,
big question for those in public health. So, obviously. Well, good. One other thing I might want to mention is that because we were having some technical issues in the beginning, we have had a WebEx tech support administrator on our webinar this entire time. Has communicated with me privately by chat, saying that he, in fact, has learned so much from this, and he's actually in India, and he was talking about the BIDI use. Exactly, and he was saying that he wishes that there were more, awareness efforts done, and he's asked me to send him a copy of the recording, so I thought that was kind of nice.
That's great, and he should definitely look up the Vardy who is referenced here, because even though he's in the U.S., he actually has a lot of publications looking at oral cancer in India.
So
that would be the perfect person for him to first look up.
So that's great. So you never know when, who or how this information is going to touch someone. So that's kind of
true.
So thank you, Dana, and thank you again for putting this together for us. We really appreciate your efforts for PCLP, all along. So thanks again. And if there's no other questions, I will go ahead and end the webinar. Thanks,
everybody.
Thank you. Bye-bye.
Bye. Are you sure?
I'm still here, but I'm going to end it.